Um, and with that, I'm very pleased to present tonight's speaker is Tyler Dillman. He's a physiotherapist and owner of One to Wellness Center here in Halifax, and he's also been a member of the network as well. So with that, I'll hand it over to you, Tyler, and to get things started. Oh, one other thing. If you could hold off on asking any questions until the end of the presentation. However, if during the presentation you have a question that just can't wait, or you're scared that you might forget it, please feel free to put it in the chat, and we'll be sure to get to it at the end of the presentation. Go ahead, Tyler.
Awesome, thank you, Shelley. First, want to thank the Atlantic Mentorship Network for having me. This is amazing to be able to kind of present on something that I feel is so important and so valuable, and especially for our profession and going this direction to help people experiencing chronic pain. So thank you for allowing me to speak on this topic today. I do call this Motivate to Move because I find as a profession and with physiotherapy, what we are trying to do is get people to be a bit more confident in their bodies, and how we do that, and how we coach people to be a little bit more comfortable in their movement and their strength to be able to optimize their function. Getting them to that place takes a lot of coaching and understanding of the biopsychosocial model. And so it can be a bit of a challenge, and bringing into some of the research and the literature that we're starting to see come out, and being able to translate that into practice is so important. So a little bit about me. A little bit of a background: master's in science in physiotherapy from Dal. That was in 2016, Bachelor of Kinesiology from Acadia in 2014, and Bachelor of Science in Psych from Mount A in 2010. Member of the Canadian Physiotherapy Association, specifically the Pain Science Division. Volunteering work experience has seen me a little bit all over the place, volunteering Dorchester Penitentiary as a youth worker, as well as a psychiatric attendant before my physiotherapy career. And I think that's more just a reflective point for me, kind of why what's kind of led me down and kind of getting into the biopsychosocial model a little bit more, and why I've tried to implement that in practice as much, because through those experiences, you really get to see, especially the psychosocial impacts and that are present, and that impact an individual's well-being from their upbringing and their genetics, into life experiences and access to resources, and the impacts of mental health, and not only the individual but the family and the social relationships. It's so important. And I'm very fortunate to have had the experience in many of those routes and those avenues. So I do a little bit of guest lecturing at the Dal School of Physiotherapy, kind of in Chronic Pain Week, and owner of One to One Wellness, and we do a chronic pain, complex pain focus. So about today's objective, hoping to learn a little bit more of the role physiotherapy plays in chronic pain management, looking at kind of scope of practice and how we navigate that in the biopsychosocial model, and then how we can incorporate the biopsychosocial model into practice for chronic pain management. We know that it's super important to understand those factors. And from like a historical perspective, physiotherapists are really kind of seen as in the biomedical physical world. And so what we're starting to see is a lot of value in patient care and outcomes for patient care when we start to implement a lot of these other psychosocial factors into our care and our treatment plans and our exercise plans. And a little bit of kind of what to expect throughout today. I'll kind of review the physiotherapy scope of practice in a nutshell, a couple of position statements that we have in the physiotherapy associations, kind of looking a little bit at the guidelines and the role of physiotherapy in chronic pain management, and then patient expectations and predictors of physical activity, which are really important. for us to be aware of, not only from a physiotherapy point of view, but I also feel generally from a healthcare provider point of view, when you're referring to physiotherapy, what are some of the things that you may be able to set kind of an expectation for, and help guide that process as well. A little bit of research into the Therapeutic Alliance and what we're seeing with kind of exercise adherence, which is really important. And then if maybe a recap for some, or an introduction to what we're seeing in some of the literature in Australia, which is cognitive functional therapy. And so starting out kind of, physiotherapy scope of practice, this is from the Nova Scotia College of Physiotherapists website. And I highlighted a few points here. And it's more than just like posture and strength and movement and manipulations and mobilizations and all of those things, what a lot of people think of when they think of physiotherapy. What our main objective is try to obtain, regain, or maintain optimal health and functional performance within our scope of practice. And what we can treat and what we can assess are a variety of different things, and the neurological conditions, musculoskeletal, cardiorespiratory, and then kind of in through the pain science, and you're seeing kind of more specialties over the course of time, like pelvic floor physio, pediatrics, and cardiorespiratory, musculoskeletal, pain science. And so there's many different specialties kind of emerging within these scopes of practice. So understanding that that's out there can be really important when you're looking to decide should you be referring to a certain practitioner based on the patient in front of you, and different connections such as in the AMN, which is wonderful. And I also think it's really important because some patients can come with an expectation as well that we are going to be kind of like curing their diseases or their syndromes, but we are really, what we're doing is trying to treat some of the physical dysfunctions that come with some of the diseases and syndromes that we see, and then also, again, the goal of maintaining or improving the overall quality of life and their overall health performance, and that can be variable based on the individual that we're seeing and what that looks like. We have our guidelines that we try to follow and get people to from a physical activity perspective and a movement perspective, what we would like them to do, but that may not be realistic for the individual in front of you, especially maybe at that time, but maybe in the future. And what our Canadian Physiotherapy Association is saying when they're putting out some of their kind of how physiotherapy can help individuals in pain. I won't get too much into this. I felt like it was important to put in here, but it's not kind of wasn't part of that process, but I do think it is really important. Collaboration, a really big one, and physiotherapists can provide really good insights into non-pharmacological care, and we can improve timely access to care as well. We are primary healthcare providers. We do not need referrals from physicians. And then looking at kind of the private practice and the public practice as well, like there's a few different options there to improve timely access. And we know in chronic pain that can be really important. I know I've experienced a few patients who've been diagnosed with CRPS that did not know that they could be referred to the pain clinic, and they would be fast tracked through that system a little bit more. And so being able to have that understanding that they can have timely access to care can be really, really important. We are able to increase awareness and education around pain and the research. We can support pain research. We can monitor population health, as well as providing some equitable approaches to some underrepresented individuals who have trouble accessing care altogether. And we're not alone with kind of these positions, right? We're seeing Australian Physiotherapy Association saying some of the same things, right? And we're able to focus in on empowerment and self-management through our pain neuroscience education, our ability to help people navigate lifestyle modifications, and again, optimizing function and independence. We're able to collaborate with other healthcare providers and come at things from a whole person perspective when we're able to kind of take in this biopsychosocial model and be able to help individuals kind of navigate some of the more, I would say, lifestyle modifications in there to just be optimizing their health overall. And then we're able to also kind of provide individual support, but also group support, which can be a big difference. Looking at just kind of overall like costs or groups, even like the People in Pain Network, and all of those can be really important. We can steer people towards those. So it's we do have a very significant role, especially when we approach it in the right way for this population group. And so the role of like a specialist physiotherapy kind of in a pain management clinic, a big key component that you're going to hear a lot of today is this patient education, because it becomes so important. And you're looking at very individualized education in the pain neuroscience education. We know that if we do a little bit too much, people can start to kind of get a little bit of belief that, okay, this is all in my head, and those types of factors that come into play that we're trying to avoid, addressing kind of just some maladaptive beliefs that it's, hurt versus harm, those types of factors. We're able to help people set very realistic goals and starting points for their movement, for their exercise, and for their treatment. And then also just providing advice on exercise management activities is really our bread and butter. How do you pace the exercises appropriately? How do we navigate anticipating pain responses or the emotions that come with moving your body or the patient's body? How do we navigate those in a way that's going to increase self-efficacy and for them to be able to adopt that say healthy behavior over time, which for us is most often the physical activity realm. And so when we're designing and developing exercise and say mobility routines or physical activity routines and optimizing function, we're starting to look at some of these functional tasks that people need to do or some of the challenges that they're having. So for instance, kind of on the right there, you're looking at the functional tasks like moving from sitting to standing, right? That can be a really significant challenge for somebody with chronic low back pain. And what do we probably need to start to work on is for people to be able to forward flex their lumbar spine. And so how do you navigate that, right? If I came at it from the perspective of you really just need to move your back and kind of bend down, touch your toes, it's going to be okay. That's not going to be a very positive experience for the most part, right? You have to try to break that down into a really safe space for individuals to be able to say, you know what, this is my starting point. This is where I feel like I'm challenging the tissues in my body. I'm challenging that movement that I'm fearful of. And then you can start to kind of layer on top of that. Maybe you start with a big deep breath, doing some pelvic tilts alongside that, creating some somatic awareness and some body awareness. And then you maybe increase that to sitting, and you're able to just keep layering those on until we're able to get to that moving from sitting to standing with a little bit, maybe not as much with a reduction in pain, but more confidence that things are going to be okay, which is quite huge. Again, kind of increase standing and walking tolerance, looking at, how do we get to strengthening the quadriceps, the gluteal musculature, same thing as walking to the toilet. How do we get to exercising the hamstrings, the quads, the glutes, basically all major muscle groups, and how do we get into balance exercises and those things, right? Going from step 0 to step 100, so just kind of walking to the toilet and telling people to do that can be challenging. But if we can break that down and section it off a little bit more, it can be a little easier to navigate for some people. And part of this too, and kind of coming into the understanding of, what are patients expecting when they're experiencing chronic pain with physiotherapy. And important for all of us to know, and especially the physiotherapists here, is the individualized training is one of those expectations that people are having. And so that comes down to understanding the person in front of you and the challenges that they're experiencing. People are expecting frequent follow-ups with physiotherapy, and I'll look at a little bit of the literature around the therapeutic alliance and what we saw in one study. But that can be quite valuable over time, and how you structure that is going to be a little bit more based on the person and their, I'd say, from a private practice perspective, like their access to extended health benefits or health plans and those types of things. Their expectations for outcomes is a very wide range. Taking a really good history and understanding that. That goes from best possible results, kind of for pain relief, to a little bit more realistic or just resign kind of regarding pain relief altogether. And then also, if some form of activity levels changing is really important. People are expecting tests and investigations when they're coming to us. So specific, say, muscle strengthening tests or neurodynamic testing, nervous system testing, those types of things. And they're expecting some form of a diagnosis and expectation of causation. This proves to be very challenging with this population group because of the complexity of chronic pain. And we know that there isn't one specific causation for the pain that they're experiencing. There's a lot of contributing factors here that we have to navigate. And then what I feel is important is kind of that bottom point, is people are expecting, in a way, to discuss their life problems. And so when we're looking at the psychosocial factors that come into play, being able to navigate those conversations in some way and being able to relate it back to our scope of practice, and then having connections to be able to say, I think that you would benefit from seeing so-and-so because they have this experience, and helping people navigate the situation that you're in can be really, really important. And using those expectations as well, we're looking at some of the guidelines that come into play, and this is through the NICE guidelines of the UK and for chronic primary and secondary chronic pain, and they recommend knowing the patient as an individual. There is to be a shared decision-making process for the treatment plan. And then remaining physically active is really important as well. And recommending the general health guidelines for physical activity, 1 to 3 days of strengthening the 10 major muscle groups. And that can happen, for those that aren't aware, that can happen with 3 exercises. So that can take away some of the major barrier of time. You're looking at about 20 minutes, 22 minutes of walking a day at moderate to vigorous activity. That's typically not a realistic starting point for individuals, and we may never see people kind of get there, but we do see some positive results in the fibromyalgia community, which I have a slide on a little bit later when we're able to kind of get into those. And mobility and flexibility and balance on a daily basis. Another thing that I don't have here, which I think is really important from these guidelines, is passive modalities are not recommended for this population group. So you're looking at TENS, IFC, ultrasound. And it's more from a socioeconomical point of view, and the cost of kind of, I would say, a session of physiotherapy and spending time on those passive modalities, and kind of what we see over the long term. From my perspective, they do have a place in pain management. That's not what I wouldn't be saying otherwise. But what I can do, I typically would say, I would teach you how to use a TENS machine, and then you can use that at home. And when during the sessions that we have, we'll focus on the education, the activity, the movement, and some manual therapy as well. And I think that's really, really important, because patients can, and those types of machines are more affordable now as well. And so changing gears just a little bit, kind of looking at predictors of physical activity. And this is with the fibromyalgia community. It becomes really important, because this is what we are trying to coach people towards and to adopt this the physical activity guidelines. And what predicts being physically active is individuals understanding the benefits and the barriers of physical activity. And so what this can look like in people experiencing fibromyalgia is you can see improvements in pain, and you can see improvements in fatigue, improvements in cognitive impairments. You see an improvement in overall quality of life. And then you also, what we see kind of when people are not being physically active is that symptoms get a little bit worse over time. But it becomes a bit of a challenge trying to get people to kind of see those benefits with when they experience kind of pain in the moment. So understanding that pain is kind of a barrier to people being physically active. Time, access to resources, motivation, all of those types of things are high. Low self-efficacy, which is kind of the next point in here, is that a big predictor is in the confidence and ability to be physically active. That is a big component here. So how, as a healthcare provider and as a physiotherapist, can we set people up for success to continue to build up their self-efficacy to be able to be a bit more physically active? Like where is that starting point, and then how do we gradually increase that over time, and what education is needed to help maybe manage a little bit of the pain that can be expected as you navigate those the increase in physical activity, and how do we keep people moving forward. Another big thing is the intention to be physically active, and what we see, and there's some literature out there, is we can have this intention and the behavior that we want. So physical activity is kind of way over here on the other side. And how do we keep bringing those closer together until we have somebody that is actually acting upon that behavior change? And simple kind of questions and curiosity in a non-judgmental way of just saying, how confident are you that you can walk 10 minutes tomorrow, right? Is it on a 0 to 10 scale? It's about 4 out of 10. Okay, so I hear that you're saying kind of 4. Why is it not a 2, right? So get them to start to kind of look a little bit at some of the things that they can do, and then you can use that to build things up. And then also kind of looking at the why not a 6? And then you're able to say, okay, those are some of the barriers that we have to watch out for. What are the fears? And so understanding this can go a long way in developing a successful treatment plan. Because when we see it overall, it is when it's implemented in being physically active and exercising, it is a game changer, not only from just from like a pain management perspective, but just from a general health perspective. This is such a physical activity is such a healthy behavior that we want to get people feeling very confident in doing. There's very few adverse events that happen with physical activity, especially when it's structured in an individualized way. It may improve pain severity. I would typically stay away from saying that it is going to improve pain. It's kind of a little bit lower quality of research that we have right now, and they're still kind of sorting through some of the theories of norepinephrine, dopamine, serotonin release, the descending pain modulation, those types of factors. But from my perspective, kind of I would say like anecdotally, what I've experienced is when you tell them that you're going to have less pain as a result of this, and they experience pain during, and maybe a little bit of a flare up, then that is going to be very harder to come back from if you kind of focus more on function and quality of life, and taking the attention away from kind of the potential pain that they're experiencing, but kind of say, this is what we should see in kind of the improvement of function. Your quality of life should improve as a result of that. But there's limitations in this research, as I mentioned a little bit there. There needs to be way more in participant numbers. They need to have a bit more broader spectrum of pain severity. You look at kind of the lengthening these interventions out, and also the follow-up period becomes really, really important as well. And kind of bringing into, I would say, the therapeutic alliance and creating that safe, non-judgmental space for people to explore, I would say a very scary thing with exercise in general. And this was with knee osteoarthritis patients. And the definition that they used for therapeutic alliance in this study was a sense of collaboration, warmth, and support between the physiotherapist and the patients or the participants. And they looked at some components of kind of mutual investment in the patient's treatment plan. Some factors that came into play was the personal interactions that the individual had with the physiotherapist. Did they feel at ease? Did they feel that there was some confidence? Their overall perception of the therapist was really, really important. And then the overall communication piece. And that comes a long way, especially the openness and honesty and trust. We really have to have real conversations with individuals who are experiencing pain. Most, I would say, and I'm about 6 years out of physiotherapy school, so it's still a little bit fresh. And I come at this maybe not from a general perspective, but from my perspective and kind of my learning through a lot of this. I came through expecting to be able to improve pain overall, right? And so if that's not the reality, you need to be able to have an honest conversation with somebody to say, I don't know if this is going to change your pain, right? Our research says it might a little bit, but we know that you'll see improvements in things over time. The listening and the summarizing is really huge. And being able to validate an individual's experience that they've had, not only with maybe physical activity, but within the healthcare system. It can be really hard for people to trust healthcare providers over if they've been experiencing pain for a long time. And then really solid explanations and reassurances that things are going to be okay. And that comes with confidence as well. And what they saw, kind of going back to a little bit of the barriers here, for people to be able to adhering to exercise was lack of motivation, time, the actual environment, the physical environment that they're in, and lack of monitoring was a big one. And the findings overall, and there was 3 groups here. I probably could have done a better job of explaining this study a little bit, and various degrees of supervision and various degrees of confidence of therapeutic alliance. And what they saw when there was a positive therapeutic alliance, it increased adherence to the exercise at the 3 and the 12-month mark. And it lasted longer, but it didn't last kind of beyond, I'd say, I do recall it's that 18-month mark. And so there is a little bit of gap there, and it's starting to say, well, do you know what? Maybe ongoing support is required. And we don't really, again, kind of going back to the Cochrane review of some of the limitations, we're looking at the length of the intervention might be really important, and looking at things like follow-ups can be really important. And what does that look like? Maybe it's structured in a way of I will see you for once a week, down to twice a week, down to once every. You're doing very well, once every month, and I want to see you quarterly, and then maybe twice a year for a couple follow-ups, make sure things are going okay. That might be it. Some people may need more, some people may need less, but it's definitely something for us to be thinking about for adherence to exercise. And this was it kind of goes into kind of the scope of practice and some of the challenges and some of the resistance that we can hit as physiotherapists when we're navigating this the psychosocial spaces and adopting things like motivational interviewing and behavior change and developing a therapeutic relationship in our practice. And going back to a little bit of the expectation, this was an actual patient encounter that I had, and I'll always remember this. And it's it said I was asking them it was a patient I've seen before, and they experienced chronic low back pain and neck pain, and they were in a flared state. And I was starting to inquire a little bit more about the stressors that were in their life at this time. And they stopped me dead in my tracks. And they said, Tyler, I came for a physiotherapist, not for a psychologist. And I was a little bit kind of thrown off. And, upon reflecting, I think I just came at that not the right way. I should have navigated it a little bit easier with some different types of questioning, or it just wasn't the right time. We just misread that situation. But the beautiful thing was, during the assessment, the individual then asked me, do you feel that the stressors I have are influencing my pain? And it just led to a great conversation around an education of how stressors can impact an individual's pain severity, and also potential other supports out there for the stressors that they're experiencing at that time. And so again, kind of going back to some of the patient expectation, although this one wasn't, the life problems and being able to navigate those conversations becomes important, and really developing empathy can be so valuable. And I just think this is just a really valuable quote for all healthcare providers to keep in mind when a patient is in front of us and they're sharing their story, and the value of listening, and being able to take what we're hearing and put ourselves in their shoes, try to understand what they're going through, and it can go a really, really long way. And that's what a lot of this literature and therapeutic alliance and the relationship in physiotherapy is trying to do, is develop that relationship, and empathy becomes a big piece of that pie. And that kind of leads me into the cognitive functional therapy piece, because a really key component of cognitive functional therapy is therapeutic alliance, and empathy, and listening, and the way that they structure their interviews, and those types of things. This is, for those who aren't familiar, this is research out of Australia, and Peter O'Sullivan has kind of headed that, and I would highly recommend looking at this. I think it's really, really important for the biopsychosocial model. And what they're ultimately trying to do is help patients make sense of their pain experience as a whole, looking at kind of maladaptive beliefs, the fear avoidance, those types of things. We're looking at exposure with control, and that's coming at things from like a movement perspective, and how do we have people understand the connections of like their emotions and their cognitions when they're moving through some very fearful movements that they've been avoiding for some time. So how do we structure that in a way to build up confidence and their ability to do that? And then also looking at behavior change principles, and how do we change some certain lifestyle factors that are important: stressors, nutrition, sleep, physical activity. There's many that can be changed, and so in being able to navigate that. And part of this, the interview process here, just to kind of put in a little bit more detail, often the starting point is tell me your story. Patients sometimes will say, where do you want me to start? And wherever you feel most comfortable, right? And what you're looking for there is just their overall pain history and contextual factors that might be coming into play. What provokes the pain, and what are some things that eases the responses, and you're using that information for potential movements and education. And you're trying to understand an individual schema about their pain, and including their overall beliefs of the cause of their pain. You're looking at emotional responses to pain, and I would say looking at fear and anxiety, and depression, sadness, those types of things. You're looking at behavioral responses to pain. What are people avoiding because of their pain? How they change their movement patterns because of their pain? What has the pain kind of, in a sense, taken away from them? And general health, how is that impacting? Levels of fatigue and other comorbidities. Looking at perceived barriers, which we discussed a little bit earlier, to engaging in healthy lifestyle practices. And then ultimately looking at what are the patient's goals and the barriers to achieve those goals and their overall expectations. And a lot of it comes down to taking all those factors, listening and summarizing that story as a whole, and then being able to come up with some treatment plans. And when you look at this kind of as a kind of a big, say, Venn diagrams, you're starting with that relationship, right? How do you have that such a positive interaction, and what factors are coming into play from both the patient in front of you and then also the clinician? And what are your biases and beliefs, and how do they fit with the patients, and how do you develop that relationship? And through all of that, you're looking at factors that are potentially modifiable with movement and activity or other healthcare providers, and which ones are not, right? In like socioeconomic status, different cultures, past history, genetics, certain pathoanatomical things. Really, we might not be able to modify. And so we need to be able to kind of navigate some of those conversations. And then to kind of the components of the cognitive and functional therapy itself, we implement those to try and get people into participating more in their community, their enjoyed activities, work, their family, trying to just potentially reduce pain overall, or reduce just the bothersomeness of pain and the amount of attention that's being paid and being paid to it at most of the time. And what they then went ahead and researched is that they use cognitive functional therapy, so those principles, versus usual care. And the way that they defined usual care was kind of the health path that was chosen by the healthcare provider or the patient, kind of more so in the community. And they had individuals trained in cognitive functional therapy, and then they used cognitive functional therapy with movement sensor data as well. And what their primary clinical outcomes was pain-related activity limitations. So they used the Ronald Morris Disability Questionnaire. Then some of the secondary clinical outcomes was pain severity, pain-specific functional scale, or patient-specific functional scale, fear of movement, adverse events. And using the cognitive functional therapy, I hope you can see my cursor here, and kind of that primary outcome where you have kind of usual care, cognitive functional therapy, and then cognitive functional therapy plus the biofeedback, the baseline numbers were all relatively consistent. And what they did is they followed up at 13 weeks and then again at 52 weeks. And using the cognitive functional therapy style, they saw a pretty significant dip in activity limitation from the patients. And so you went from the baseline of 13 to a baseline of 11, and then a baseline of 13 to a baseline of 6.7, and then a 6.1. And so that's quite significant. And then you're going down to patient-specific functional scores. Again, not a whole lot of change in the usual care group. A couple point difference in self-efficacy and the perceived ability to do a task with the CFT, and again with the biofeedback. Pain reduction was present in this this study in all groups, but a little bit more so in the cognitive functional therapy groups. And you're looking at the physical activity subscales. So there was a lot of positive changes that happened as a result of the cognitive functional therapy, which in turn really starts to incorporate this biopsychosocial model of care into the physiotherapy space. and showing the impact that it can have on patient care and overall activity levels is there. And this is it's definitely getting more well researched, and I'm really excited to see kind of the development of this within our profession, because it's really important. And as we know, the complex nature of chronic pain, we do need to come at things from all different angles, and being able to collaborate with all of that as well is really important. So that is all I have for today. And I hope you were really able to take away and kind of see how we're, as a profession, we're getting to the biopsychosocial model, how physiotherapists are able to implement this into their practice through certain kind of interview questions, and using therapeutic alliance and psychological principles in their practice, how we can pace and grade exercises in a really individual way to increase like self-efficacy, to get people a little bit more physically active with a little bit of pain reduction. So yes, thank you very, very much.
Thank you, Tyler. I'm going to open it up to questions for Tyler, or comments. Any comments folks may have?
Hi, Shelley. It's just Maureen. Can you hear me?
We can.
Okay. Thanks, Tyler. That was awesome. I teach a course. I'm a medical practitioner in a rural community, but I've been teaching sort of an introduction to pain to the human kinetics students. And every year I keep saying to them, if anybody goes into physiotherapy and actually does a practice specific for chronic pain, they're going to have a huge practice. So it's so exciting to see a physiotherapist that actually is very focused on chronic pain. One of the things that kept coming up for me, Tyler, actually, as you're going through your presentation, was I'm not sure if you're familiar with pain reprocessing therapy. Have you heard anything about that?
No, but I would love to learn more by the sounds of that.
Well, everything. So what I like about the pain reprocessing therapy, because it's not specific to physio, but for all of us that work in this field, we're going to meet patients where they are and using our specific kind of expertise. But what's beautiful about pain reprocessing therapy is it really brings in a lot of the principles you're talking about, but it does it in a way that is very, very lighthearted, a lot of humor. It's really allowing patients, it's sort of based on a concept of mindfulness and acceptance commitment therapy. So you're actually getting them to lean into the pain if it feels safe to do. So these are typically patients with moderate to low pain. So when they're having that high intensity, obviously it's going to be very difficult to do anything like somatic tracking. But the principles and the process, I think, is something that anyone that works in the area of pain should be incorporating into their practice. And it actually makes it really fun, believe it or not, very lighthearted. And I mean, I actually got a call today from a clinician who's working with a patient, an inpatient in the hospital, and having a gentleman with chronic pain, but in having so much pain that he's actually not even able to try and stand, and there's nothing secondary going on. So what I stressed to her is about getting a physiotherapist that had an understanding of chronic pain, who could actually start to develop a program. The safest place he felt was actually on the bed. That he didn't feel safe standing up. He didn't feel safe trying to move because he was so fearful of the muscle spasms. So giving him some very safe movements, lying in bed, just so that he could start to do some movement, and then gradually bringing him a little bit further. But such an important part. I couldn't do my job without physiotherapists. I love them. Love them.
Well, thank you. And kind of leaning kind of into the pain a little bit there, kind of brought up, and for the patients that you were mentioning, the edge work is such a kind of an important piece of helping people kind of navigate those edges and the safety zones of movement. And in using, I like to use personally kind of in like somatic exercises and coordinated with the breath, because of just trying to really keep things as calm as possible as you explore those movements, especially those early phases, can go such a long way. Yeah.
Well, you can even, as a physiotherapist, I mean, one of our physiotherapists in our clinic, she literally will spend sometimes in her clinic just sitting and talking with patients the whole session. Like there's not even a discussion around movement at that point. They're just kind of talking things through. And by the time the patient is often very grateful, even for that opportunity. And I think that's why professions like yours do so well, because you spend the time with the patient that they need. And you also have the hands-on as well, which is really important.
And our research is really coming along too with the virtual sessions and coaching people through that as well. And the COVID-19 pandemic really kind of brought that to light for everyone, but we're seeing a lot of positive results and just kind of really that education piece and that reassurance to help people kind of navigate moving with pain and kind of those starting points. It's fun.
Any other questions or comments for Tyler? Tyler, I'm going to ask you a question. Can you
Sure.
can you talk about the importance of collaboration with other healthcare providers, other members of the team, and how you may facilitate communication with the team outside of your own practice?
Yeah, and it's one of the what I believe is such a key factor is finding that right team, because especially when it comes to individuals experiencing pain, and I find that if there's one kind of, I would say, hole in the bucket that is saying communicating something different, it becomes that much more challenging, that much more confusing to navigate a confusing, an already confusing phenomena, I guess. Experience is a better word. And so it is certainly challenging when not having everyone in kind of one place, but ensuring doctor communication is kind of key. And whether it be like reports being sent, phone calls being made, those types of things are really important. So that's how I would typically navigate the collaborative, whether it be kind of email and phoning admin and or just sending a fax with a question if that's the easiest route. And so I would ideally, I think all of us would love to see some form of just kind of being able to network, no matter who's in their care, some form of communication being able to be a little bit easier to navigate. But ultimately, how I would facilitate it, to answer your question in short, is via kind of phone calls and reports from my perspective. But it's beyond important. It's we have this biopsychosocial model and trying to blend everything. And one of the biggest things that I learned is you can't do it all. You can't be everything for that person in front of you. And also there are people way better at things than I am. So using people's strengths and their skill sets that are aligned with yours to keep people moving forward is so important. And you really can't do it yourself.